First of all, thank you all for participating in this. Hopefully it'll be fun, and certainly I hope as we go along that there'll be some useful information for the people that will view this. This meeting is really being sponsored by ClickSmart, which is an Australian company that specializes in removing scalpel blades from handles, amongst other things, but safety. And OR Safe, which is a new blog, if you will, that covers everything in theory that has anything to do with safety in the OR. And if I can go around to just introduce the people that will be taking part in this panel discussion is, first of all, Dr. Amber Mitchell, who's the Executive Director of the International Safety Center, which is a depository for injuries data collected from quite a few different hospitals around the country and published annually. This is a very useful tool for anyone in nurse education as a means to be able to show new nurses and some of nurses that have been around for some periods of time what is actually happening out there in the trenches, so to speak. I have Sharon McNamara, who's the past president of the AORN. She's a consultant, perioperative services specialist for DX and RX solutions. Monica Young, who's the vice president of perioperative services at Thomas Jefferson University Hospital in Philadelphia. Vanjie Dennis, the executive director of Wellstar Atlanta Medical Center, and also a smoke and or plume specialist as a sideline passion. Brenda Ulmer, an independent nurse, educator, perioperative services, equally an advocate of smoke and plumes. So I'm sure both Angie and Brenda will bring a lot to the discussions. Pat Muse, who's a perioperative management consultant out of Arizona, and myself, the editor of orsafe.org. Hopefully you'll find this webinar interesting, but I think I'd like to start with Amber, if you would, describing EpiNet Services, your international safety group. That might be the easiest way to go because you'll have a fair amount of data that's available that other people might enjoy seeing. So if I turn it over to you, Amber.
Sure, thank you. Thanks for the invitation and thanks to everybody. I'm excited for this discussion we have today. Can you see my screen okay?
Yes.
Yes.
So we're going to start with sharing some occupational incident data from hospital settings from a broad sense, but also specifically in the operating room. EpiNet has been around since the early 1990s. It was in place as the surveillance system that was created by one of my mentors, Janine Jager, at the University of Virginia Medical Center. And these are what the EpiNet forms look like. So what happens when an employee has either a mucocutaneous exposure or a sharp object injury or a needle stick, they would go to employee or occupational health, and then these forms serve as the incident report forms for those types of exposures, providing a lot of detail about what devices are causing the injuries, where they're occurring, whether they were using a safety design with a sharp injury prevention feature or not. So it's used around the world, and all of our data is available publicly for free for anybody that wants to use it as benchmarking data or comparison data. The data sets themselves are about 40 U.S. Healthcare institutions that make up the collaborative of data. And when we compare our data, for example, to Massachusetts, which is the only state that requires reporting of all their licensed hospitals to the state, it looks extremely familiar. So we know that this data is generalizable to all different kinds of healthcare facilities across the U.S. So it's a really simple Microsoft Access database. It is not software. It's just a Microsoft Access program. It's available for free, meaning if anybody's interested in using EpiNet, we would be happy to send it to you for free. So what I like to do, 2020 is going to look very differently given the COVID pandemic. But over time, I just wanted to show that needle sticks are decreasing for the first time in several years, actually, very slightly. But when we look at the differences between teaching facilities or academic medical institutions versus non-teaching, they are traditionally higher, which is what you would really expect given that clinicians are learning. When we look at the data over the entire health system, who the injuries are happening to, it used to be that nurses were consistently the highest numbers or highest percentages of those sustaining Sharps injuries. But over the last several years, it's been about equal between physicians and nurses, and you can see a breakdown of all the others. Now, the data that's available on our website is much more detailed than this. I just wanted to give a broad overview of what the professional groups look like. Disposable syringes continue to be the highest as a general category in years past. For the last 3 years, though, suture needles have been the most prevalent injury type. And so this is for all healthcare facilities, meaning the entire hospital. But when you look at the OR, suture injuries are about 50% or more of all injuries, with blades, with disposable syringes being next, and then blades. And we capture data on whether the blade was reusable or disposable. In general, the largest proportion of disposable syringe injuries are both from those used for vaccinations and for insulin. And this is a public health trend that we're not liking, which is with the increasing rise of type 2 diabetes, we're seeing more and more injuries with the use of insulin syringes. And the majority of these are in patient rooms, number one, and number two, in operating rooms, mostly for local anesthesia. So EpiNet will ask if the injury occurred, was it used with a safety device, yes or no? And if it was used with a safety device, was it the safety feature activated or not? So of the more than half of people who got injured and they said, yes, I was using safety, it's only just more than 50%, which we would hope would be a lot higher. But more than 70% said, I was using a safety device, but I did not activate the safety feature. It's important when we capture injury data that we capture whether that injury happened to the user of the device or to a non-user. And the reason why this is so important, especially as we think about sterile processing and environmental services, is that when an injury happens downstream, meaning to the non-user, sometimes it may be impossible to identify who the source patient was. So this picture was taken by one of my heroes, Earl Doddard. He's taken pictures in workplace settings all around the world. This is one that's at the Brooklyn Central Laundry. So these are linen workers that have linens that come in from the healthcare facilities to be processed at the Central Laundry. And this is just an actual picture of the devices that they found in the linen. So what happens with these injuries, since the source patient is not identifiable, most traditionally they would undergo really rigorous post-exposure medical follow-up and a lot of uncertainties about what the risk was when they sustained that injury. So again, these non-user injuries are about a quarter of all of the injuries that are reported through occupational health. And I wanted to just go quickly through here. So these are mucocutaneous exposures. So these are splashes and splatters. And the reason why I wanted to focus here, just as my last point, is that typically about 50% of all mucocutaneous exposures, so these are splashes and splatters again of blood or body fluids to employees, happen to the eyes. And the reason why this is really meaningful right now, especially, there's so much focus on respiratory protection for preventing COVID-19 or exposure to the SARS-CoV-2 virus. So we're set on a lot of respiratory protection from that point of view, which is the nose and mouth. But almost 50% of all of these exposures are actually happening to the eyes. And so the eyes are a mucous membrane, rich also in blood vessels. So any potential contaminant, whether it's a bloodborne pathogen or bacterial pathogen like MRSA or a virus like SARS-CoV-2, these are substantial exposures that we really need to prevent, which is why I think data for 2020 with the COVID pandemic going on is going to look very different. And the reason why this is meaningful is because if you look at the exposures that are happening to the eyes, which is that blue bar, the orange bar actually says when they were wearing eye protection or not. So 50% is 50% on average of all of the exposures are to the eyes, and then you look way down at the orange bar. In 2019, less than 4% of people who say they had an eye exposure are actually wearing eye protection. So this is really crucial information to capture, not just where the exposures are happening, but whether they had the appropriate personal protective equipment or not. So I'll end there and happily make these slides available to whomever wants them.
All right, well, one of the things that I do want to talk about is some of the different bloodborne pathogen issues, but since we've got Amber still on, what's your feeling right now on what OSHA is doing as far as bloodborne pathogen restrictions?
I happen to work with OSHA on a regular basis, and for those that don't know, I was the very first OSHA National Bloodborne Pathogens Coordinator. So that was 20 years ago, and we did a lot of directed regional emphasis, national emphasis programs, including hospitals, nursing homes, for bloodborne pathogens. I think they're under a lot of scrutiny right now for not being at the front lines, but I will tell you they're putting more and more documentation out there for assistance with occupational exposures to COVID-19 relative to an infectious disease, meaning an aerosolized infectious disease. So as it relates to bloodborne pathogens, though, and the enforcement of the bloodborne pathogen standards, since most of those inspections do take place in healthcare, I'm really not sure. There are ongoing reactions to people who file complaints or referral programs or follow-up inspections, and whether they're doing enough or not enough, or whether they're going to get back to doing inspections, it's really hard to tell right now. I'm willing to give them a break, but the American public seems to be very critical of them at this time, especially in healthcare.
Well, Amber, let me ask you this question. One of the things I do is run around the country talking about sharps injuries. What's interesting is over 5 years ago when I first started giving sharps talks, and I asked how many people have had a needle stick and or how many people have had a scalpel blade cut, raise your hand, and virtually no one would raise their hand. Now, which we obviously know is nonsense. But now when I ask the question, and certainly the last 2 years, I'll get half the room raising their hands. And it's interesting, those that are over 40, 45 are more likely to tell you they have a problem than anybody underneath. See, we've watched OSHA do a number of things. For example, I guess it was the summer of 2015, a letter went out to all of the OSHA offices asking them to start inspecting independent of the Joint Commission, and they started fining. There's a number of fines that you can find on the OSHA website, and some of them are significant for bloodborne pathogen issues. But also the number of nurses that I've found that don't seem to be terribly excited about scalpel blade cuts or needle sticks is still relatively high. There's so much focus on the patient and so little focus on staff, and that's concerning. Do you have any comments or anybody on that?
Well, I can comment on that, Alan. I think it's kind of a historical thing for nurses. Exposure to bloodborne pathogens, getting cut and so on was just kind of part of the job. I think when you ask a lot of those nurses over 45, they probably didn't even admit that they got cut at the time or didn't even report it. And I still believe that that's going on a lot today. It goes back to the culture of safety and that we're building that. So I think people are more comfortable speaking out now, but I don't think we are where we need to be. I also think to what Amber spoke to is, OSHA's had regulations in place, but there really hasn't been any hard line to hold people to them. And so the hospitals didn't see any, I hate to say punitive, but that's what it gets to be when you don't comply, and then they have to come and be punitive in their way of giving fines and so on. They don't see any reason, it gets put to the back. I'm not saying it's a conscious thing, but I think it gets put to the back of the long list of things that they have to do. There's definite pieces of the OSHA guidelines that have to be put into place. And I'm amazed when I go out in my consulting role and see people that they don't have safety programs. They don't have the bloodborne pathogen programs when you start to ask the staff questions about what would happen if you got an exposure and so on. Oh, that's a big problem. And we go to the emergency room, we sit and, this, you would think in this day and age, with specific guidelines should be ironed out, but it isn't. It's still very prevalent that our staff are not being protected. And I think I can say that if we do not have safe staff, we do not have safe patients. And I think this is something that needs to be embedded in the cultures.
Absolutely.
I don't think that's happening.
Pat, do you have any comments on that?
Well, I agree with you, Sharon. In my experiences, especially when a tech gets stuck by a needle or something, it's kind of like they want to brush it off because they don't want to go to the emergency room and they don't want anybody to know that they made a mistake. They feel like they made a mistake, even though it might have been a resident that stuck them or it might have just been carelessness. So again, unless there's a policy that specifically states, and I think that's where we're lacking in a lot of hospitals. In my consulting role, I see the same thing happening. And the RN that's in the room doesn't seem to enforce, even though that should be the leader in that room when something like that happens. They should be able to say, let's stop, we're going to take care of this and do whatever their policy says. And hopefully they have a policy, but again, a lot of them don't have good policies.
Well, they certainly don't seem to have the meet the standards. If you look at some states like Tennessee, for example, seems to be ahead of most of the others in terms of actually physically going after people for their SHARPS programs, whether it's the logs that they're supposed to keep or how things are reported. They started, I guess, 6-7 years ago. They had a 5-year push where they literally went to every surgery center you can imagine and quite a few of the hospitals and started fining facilities anywhere from $1,500 to $2,000 per incident. And that seemed to have a major effect. On the other hand, if you look at places like in New York, there's a major facility that takes up half of New York City. They were fined recently $200,000 for their bloodborne pathogen lack of structure, as where a surgery center in New Jersey, which was another one, and there have been many others. I don't know that there's any way to turn around and get the the hospitals to really understand that when you're protecting the patient, that's great. But if you're not protecting your staff, what's the point? You can't have half an equation filled and expect to have a good result.
That's right. This is, I pulled up for everybody, inspection data is public information, and I pulled up the code for healthcare and social assistance, which includes all hospitals, nursing homes, clinics. You can see here that the #1 cited standard for any facility in healthcare is the bloodborne pathogen standard, and this has not changed in 20 years. So inspections are continuing to go, and once the citations are issued and released publicly, they would show up here. I can tell you though, relative to, and I'll stop sharing, here's our EpiNet data. I just wanted to show you, this is the more detailed report that you can see based on this information. More than 40% of all sharp injuries are occurring in the operating room. And then if you go down to which device was used, you were talking specifically about scalpel blades, you know, the reusable scalpel blades, disposable scalpel blades, you know, tend to make up 5 or 6% of any injury that happens. And a lot of these, as you were talking about, do happen to the non-user, meaning they're happening during passing of instruments. So that's another example, I think, of where those injuries to the non-users can be devastating to somebody who may feel like they're not in control when the surgeon is using the device or when it's being disposed of improperly.
Oh,
Amber, I noticed when I looked up EpiNet's, the different hospitals that were reporting, maybe I'm not looking at it correctly, but I did not see anything in Arizona.
Yeah, well, then we would welcome any facility. As I mentioned, the EpiNet is free for anybody to use, and hundreds of hospitals, maybe even thousands of hospitals in the U.S. use it, but not all of them contribute to our aggregate data set. So we do not represent 50 states for sure, but when we compare our data to data in other states like Massachusetts, Texas, or other reporting systems, the data does look very similar. But anybody out there who's in Arizona who wants to contribute their aggregate data to us, we would be overjoyed. The more data, the better.
Sharon, you had a question.
Yeah, I just wanted to make a comment. I thought it was interesting on the EpiNet information also that almost 72% did not activate the safety feature on the device. And I think we're seeing a lot of that out there, especially I see that with the safety scalpels. And this gets back to that culture again, where you've got a surge tech or a nurse scrubbed, and the doctor wants the scalpel, but he wants them to open the scalpel and hand it to him. And I see a lot of that out there, and it's just very interesting that, you know, here we've discounted the whole device and what the purpose of it is. We're spending money and they're not using the devices it's meant to be used. And that's how we're continuing to see these incidences happen. So it's, again, a part of the culture where we have got to start, I think the way sometimes we introduce things in the operating room, we're in a big hurry. Okay, we're going to introduce safety scalpels. We've had 10 doctors look at them and they've chosen this scalpel and we're going to implement it or we're going to do a trial, whatever. And then the other 100 haven't seen it, don't know anything about it, and it shows up in their room, and then they just say to the tech, just open it for me. And so that becomes the practice. And it's really a shame, but those kind of things, we got to start back at the beginning at the leadership level and bring that culture down so that everybody is on the same page. We got the same shared mental model of what our goal is and how we're going to get there. And that we start using these things appropriately. But I think the introduction of them sometimes is not done well. It isn't disseminated, and you immediately get that resistance when people don't understand what's going on and they feel like things are being jammed down their throats, is what you'll hear from the docs. So I think that's an important piece of this whole thing also.
One of the, go ahead. Who's?
This is Vanjie. In actual practice, I have 2 centers there. And what OSHA says, I've actually had 2 OSHA visits. It says when a workplace practice is in place, you can eliminate engineering controls, which a guarded blade is an engineering control. And a workplace practice is the implementation of the neutral zone.
Right.
We practice neutral zone on hands-free passing. Most of my blade exposures, and we do report, are usually blades left on the knife handles that arrive in sterile processing. I don't see as many. I don't think I've even had a blade stick. It's mainly recapping needles when they shouldn't be doing that too. But most of the time, the implementation of a guarded blade within surgery is a cultural thing. I agree. But there's also a rhythm, and Brenda and I teach a lot about rhythm and culture of surgery. We've interrupted the culture of surgery by putting a device that doesn't give the feel of a normal knife handle and blade that they're already accustomed to. And I've done a lot of studies on products prior to implementation of their design, and one of the key indicators is to create a guarded blade that was much like what they're already used to.
Well, let me throw a thought out to you, if I may, and that's the, from what I see, is typically when people are using safety scalpels, the biggest laugh that I always get is how many times have you seen a safety scalpel put into a neutral zone that hasn't been properly closed? And that usually is met with hysterical laughter because it's so common.
But if it's in the neutral zone, then they're not going to be sticking themselves, correct? It should be in the neutral zone.
That sounds great, but it doesn't really work that way, because in many facilities that I've gone to, what you end up seeing is someone gets distracted by another person in the room while they're sticking their hand into the emesis ball or whatever you're using as a neutral zone, and then gets cut. There's 12 to 15,000 cuts a year, of which 40% are used blades. So they've got to be happening somewhere.
So is the data coming from people having their cut with blades? Is it the scrub tech or is it an SPD? That's where most of my sticks are.
Good question. I can't answer that. Sharon, you might know. I don't know.
I do not know, but I wonder in that case, and Vanjie, this would be interesting, but if there was some way in the debrief to make the disarming of the knife handle part of that, to solve that.
Yeah, the knife hand, yeah. I mean, that's what we were looking at, where it had to be the device, and of course this never went to production. I'm trying to think of the name of the company I looked at, but we had doctors, physicians, and surgeons look at this guarded blade, because it has to be able to spring back, lock and spring back, and the design has been so poor on the blade design. The people that use the guarded blades are the disposable blades, like the procedural areas, ED, IR, places like that only take one stab. Yeah.
I think what you're talking about is pen blade.
Yeah, pen blades, you're right.
That was the unit that it seemed like a great idea at the time, but still it's plastic, and a lot of people have a problem with it being slippery when you hold it.
Yeah, they don't like it.
Visibility is an issue, and that's why more than quite a few people always end up going back to the standard handle. It's still 70% of all the blades used in the country.
So I pulled up our EpiNet data. I didn't have it for 2019, but I do happen to have it for 2018. So you can see here, this is reusable and disposable scalpel blades only. And these are the job categories that they're happening to. So almost 50% to the physician, 22.7% to the nurse, and as you were saying, the next highest majority is to the surgical tech. Here, though, we didn't have enough numbers for sterile processing, so it doesn't actually show up. But again, these are just the facilities that report into our aggregate. It doesn't mean that they're not including a lot of those sterile processing injuries for sure.
Do you think any of this could be caused by the pressure to change the OR over to the next patient to do things as quickly as possible? Pat?
I don't think so. I think if you have a good process in place in how you handle your sharps, trying to implement the efficiencies, and if they keep a back table that's organized, I don't think efficiency should have any impact on it.
Anybody else want to comment on that?
I think a little differently than Brenda does. Or not Brenda, I'm sorry, Pat. I think it does. I've seen, they're pushing for the turnover and, pull the drapes off. They get the instrument set. They throw the instruments in. Now, if you've got a good process for returning and starting the decontamination process, which starts in the OR, then they should have to kind of put that tray back together somewhat. And it should be organized, as Pat was saying, throughout the procedure. And then you would notice, I would think that, but they're not. They're tossing them all in there, and then it gets down to the central supply area, and they go into the, the tray to rinse the stuff and wind up with an injury. But I do think that the turnaround time does have some push. I think the push for that throughput is definitely an issue with the end of case cleanup and sharps injuries. Yes.
Yeah, well, before we go on, let me change this discussion slightly and ask either Brenda or Vanjie to talk a little bit about other issues that are of concern, and smoke being one of them. So whichever one would care to comment, feel free to jump in.
Brenda, you can start. We've been joined at the hip for years on this smoke. Started 30 years with lasers, and it just never made sense that lasers produce a smoke, and but we do the same thing. Why we didn't do standard precautions for the removal of smoke? But Brenda's been pushing the bandwagon early with law back as early as in the early 90s. So I'll let you start.
Well, my expertise and experience runs along with heat-generated devices that are used in the operating room, laser, electrosurgery, ultrasonics, all of the components used to stop bleeding in the operating room. And a byproduct of stopping bleeding in the operating room is surgical smoke or plume. There are a lot of different names that people call it by. I use smoke. That's my own personal preference. So electrosurgery safety, surrounding fires, inadvertent patient burns related to electrosurgery, and then surgical smoke. We've been trying, as Vanjie said, for a number of years to get national laws. We went through OSHA first, and now through AORN, we're going honestly state by state, trying to get legislation in each state, because we've had very little response from national organizations about the hazards of surgical smoke. 2 states, Rhode Island and Colorado, passed legislation in the last year and a half. In the 2020 session, there were 14 or so states who were pursuing legislation and were successful at different levels. And then we had COVID, and so everything just sort of shut down. What happened here in Georgia is that our senator introduced a resolution to set up a surgical smoke study committee through the Georgia Senate for the summer and fall, and that's what we have. We have our first study committee meeting on September 15th, 2 hours with the 5 senators in the Georgia House, and then we'll have another 2-hour meeting in October and one in November. So our focus at this point is to educate our legislators related to the hazards of perioperative team members inhaling surgical smoke from 8, 10, 12 hours a day. What has happened in the meantime with COVID and the silver lining, if there is such a thing, is that 3 of the surgeon organizations that were not all of them were in opposition of surgical smoke, but they've come out now in support of evacuating smoke because of COVID. American College of Surgeons, SAGES, the Society of American Gastroendoscopic Surgeons, and then I'm blanking on the other one. So, no, not Colorado. It's the women's laparoscopic.
Oh.
I didn't hear you.
NACOG?
No, not NACOG. NACOG's men and women. Oh shoot, I'll think of it in a minute. I've got it written down somewhere. Anyway, we now have 3 national organizations who recommend smoke, with SAGES being, to me, the very best one in recommending smoke evacuation routinely at a level 1 on the hierarchy of controls from NIOSH. So we think we have a good opportunity to affect some change in Georgia, because there are still surgeons who say we don't need to evacuate smoke because we lack level 1 research, when we are not going to do level 1 research on human beings who work in the operating room. It would be unethical to do so. So we have tons of peer-reviewed published research data, and now some organizations who think because of COVID that we do need to evacuate smoke, and organizations such as OSHA saying that you should use standard precautions. So we think the genie's out of the bottle on this one, and that you can't all of a sudden, because of COVID, say you've got to evacuate smoke, because it's a virus like HPV and HIV, which have been isolated in surgical smoke. And if there's the possibility of one being there, there's the possibility of the others being in surgical smoke as well. So that's our focus, is to try to have that implemented as standard practice in hospitals, not just in the US, but all around the world. And there are many consensus organizations who agree with that. All of the nursing organizations recommend the evacuation of surgical smoke. And we think it's an employee safety issue, because it's nurses and technicians and allied personnel who are in operating rooms at least 5 days a week, 40 hours or more a week, in some cases 7 days a week. They're the people that we want to see protected, the employees who are exposed to it.
Were you not having some success in California?
There has been some success in California. The bill to have a law on smoke evacuation got to Jerry Brown's desk twice. This last time he referred it to OSHA in California. In California, OSHA is a different animal than national OSHA is. And so they are still grappling with what to do with that in California. And I think they were having some success with it. But I think, like the rest of the country with COVID, that sort of got put on the back burner in California. But yes, they did. And there are several states who think that they will be successful in legislation in 2021. Oregon got all the way to a vote on the bill, and they sort of got sold off by the Oregon Nurses Association, so I'm told. They swapped off, you pass this and we'll drop this. It's political. So anytime you have to go through the political process, it's a mixed bag.
Well, when we talk about these issues that are safety concerns, How much do you think the finance, the CFO of the hospitals and/or surgery centers, play a role in this?
Well, from my perspective, the American Hospital Association is one of the big organizations that opposes smoke evacuation, and they do it on cost. I took an invoice from a major metropolitan Atlanta hospital, which shall remain nameless, Banji, and tried to, or did actually calculate out the cost with each way of evacuating smoke by procedure, and it ranged from $1.67 per procedure, with, if you only have to use an inline filter and a smoke pencil, up to about $13 if you're using a dedicated smoke evacuator. So cost is not the issue, but the opponents have done a good job of selling that it would break the bank. But, you know, even $15 per patient per procedure is not, that's probably one of the least expensive things in the operating room.
Yeah.
There aren't very many things that you can get by with just $15, $20.
Mm-hmm.
The push is always that the rural hospitals cannot afford that kind of an up for each of their procedures. That's usually what the hospital association is pushing.
It is. That is what they said.
Yeah.
But they can't afford.
It's not true.
I don't
Yeah.
believe it.
It's not true. I've had 3 full conversions over 35 years of implementation of standard precautions for surgical smoke. It's from the inline filter at $1.67 that's amortized on a certain limited life usage. They look at the whole cost of the pencil. It's not the whole cost. It is what the adapter is to the pencil, the smoke adapter. And some use the corrugated tubing, and my corrugated tubing is $2. And capital today is under the threshold. It's not capital into your operational budget where they can buy the piece of equipment. I mean, if I have an instrument, those of you that were in director's positions, you know one instrument replacement can be $2,000. I can buy a smoke evacuator for $1,900 a room. So the cost is not the real issue. It really isn't.
What's interesting there is if you look at, if I can go back to Sharps for one moment and put my ClickSmart hat on for one moment, they came up with an idea called I guess it's a value-added calculator, and the idea was to be able to look at what it really costs a hospital not to be paying attention to these safety issues. One of the things that they looked at was obviously Sharps. And they found that most hospitals, when they look at what their costs are, only track the cost of the loss of the nurse maybe for 3 or 4 hours in the ER, and the cost of the blade, and that's it. But if they start looking at other things, like what does it really cost to do the blood tests 3 times a year, which is typical, when you get cut or when you get a needle stick, 3 months later, another set of blood tests, a year later, another set. There's a cost associated with that. There's another cost that's associated with litigation. And one of the things that they managed to do is do literature searches across the board. And they found that if you plug in different numbers into this value added calculator, you could get a better idea of what it's really costing you because you haven't looked at it in the appropriate way. Mm-hmm. And there's a company too called C2AI, which I'm always very impressed with, that does have software that allows you to drill down and look at things like that. And by drilling down, not just one level, they go right down to the individual doctor, the individual bed, and they can tell you what your true costs are. And that's phenomenal.
Yeah.
I'd like to add something to that too. So one of the reasons why people don't know what the injuries actually cost is because a lot of times workers' compensation will pick up that cost, which is completely separate from the hospital's cost, so they legitimately don't know. We actually capture cost data in EpiNet, but most occupational or employee health nurses or infectious disease physicians don't have any idea what the cost is, so they don't put it down. So our data is not all that useful because it's only for people that might know. But when we're talking about those non-users, meaning somebody in sterile processing, somebody in CSSD that gets injured, somebody who is cleaning up after a case, those injuries tend to be the highest cost because, again, it may not be possible to identify who the source patient was to do that baseline HIV testing, hepatitis C testing, whatever it is. So they'll have to run, more rigorous post-exposure prophylaxis, and so those injuries end up costing a lot more. But again, when workers' compensation picks up the cost of those prices or those procedures or that follow-up, the facility itself may never keep track of that. So cost assessment has been incredibly difficult. I do want to make one clarification, though. Because OSHA standards are in place, an employee may not ever sue their employee for safety and health breaches. So litigation in this case would not be an option.
It's funny that you say that because myself and Dr. Sinnott, who's a colleague, were recently in Michigan. And out of idle curiosity, we called on 4 different attorneys that specialized in personal injury. Every one of them had a nurse in it. Now, granted, most of the time when that occurs, it's usually a back injury or it's workplace violence, something like that. But one of the 4 was for bloodborne pathogens.
Well, I'd like to see that because workplace violence, ergonomics, that makes sense because there are no specific OSHA standards for it, but there is a standard for bloodborne pathogens, which would mean in order for that nurse to sue the facility, they must not be an employee. So it might have been after the fact.
Could be. Don't know because we couldn't get any more information than what I just shared.
Yeah,
I know Michael Sennett quite well.
I have experienced in one of the institutions I worked with an employee that sued.
It happens.
Yeah. I don't know what the outcome was. She wasn't able to talk about it, but yeah.
All right. We're talking about culture and we're talking about changing culture. What do you do? Does it have to be legislation, or is there some message that people can put out there that will actually force a change in how people do their job from a cultural point of view? Anybody want to jump in on that, or do I have to define it more?
Well, I mean, how long did it take for surgeons to start wearing gloves? It took a really long time. It took a long time to switch from reusable gowns to disposable gowns. And I mean, I worked at Emory University Hospital in Atlanta, and we used to make bets on where people went to medical school based on how they made their incisions. Because once the surgeon learns how to do something a certain way, without an overriding reason to do so, they aren't going to change. So, I mean, that was in jest, but that's not totally untrue. So it takes a lot of time and persistence on the part of people who, I mean, how long did it take to get scavengers on anesthesia machines? And
Right.
working in the operating room kept having spontaneous abortions from breathing those gases. And it was a simple fix, but it took a long time to have the scavenger units built into the anesthesia machines. And what happens with surgical smoke is that it takes so long for symptoms to manifest. And in some people, they never do. It's like cigarette smoking. Some people smoke all their lives and never have anything related to that. Others don't even smoke and get lung cancer. So it's a wide variation of symptoms among people over a long period of time. And, I really hate to say this, but it's an issue for the people on the lowest rung of the ladder in the hospital, and that's the nurse and the technician, who are the employees. If you had surgeons who uniformly went in to hospitals and said, I am not doing a case without evacuating surgical smoke, it would be done immediately.
Mhm. Mhm.
Oh,
Mission.
go ahead.
Also, when I look at my consulting, so much involves change, and it takes time for the change. When I worked at Johnson & Johnson and we were a group that would go into a hospital, we would say to them, don't expect the change in a couple of months. It will probably take a year. It might even take 18 months, depending on how you put your teams together and the people that you put on the teams. There was a study done at Beth Israel up in Boston, and Elena, can't pronounce her last name.
Carrie.
Erna Carey. Anyway, she was involved in workplace safety, and she did a gap analysis with a management engineer who came from industry, and it goes through the entire process of engineering controls, the hazards, the workplace practice controls, how we have to get administration to help us, how we have to, track everything, where is it going, and we need to share it with everybody. So when we look at the culture takes a long time, but you need the stakeholders in some of these meetings, and it needs to be posted. Today we had 0. This week we had 2, and posted by day, then by week, then by month. And when we see that and we see who's on these committees, and it, like I say, it can't just happen in a month or in 3 months. You have to continue with it, and it's a daily thing to make sure that everybody's safe. And whether it's sharps, personal protective equipment, smoke, it all goes together. It comes under safety. We always say safety for the patient, but we have to have safety for our employees.
I just wanted to comment as far as an administrator that it's really hard to get surgeons to change and to comply with things. But when it is a Joint Commission requirement, they comply. I mean, they know it's what they have to do. And when we've tried to implement different sharps or smoke evacuation, it was always, it's recommended, but it's not required. The sharps part, we know that we have to have a safety blade available in the room to be used, but they're not all using it. I think that it has to come from a regulatory body that says, this is required, this is what you need to do, and we will measure this when we come out for our visit. Because otherwise, when you're giving people options, there's too many people who are going to default to the, if I don't have to do it, I'm not going to do it. And it's not an expense at our hospital. We bought all this stuff. We bought all the, we have available all the safety things for both sharps and smoke evacuation. But the compliance of use is not where I would like to see it. And it probably won't be there until we tell them that it is a requirement that they have to do it. And so that's just my experience.
You bring up a really good point, I think, which is the difference in driving. I think culture has to be personal. I mean, you have to be the model of safety, every single person. That's really the only way to do it. But interesting difference between OSHA requirements and Joint Commission standards, because I think you're absolutely right. Joint Commission compliance drives dollars, so it drives Medicare dollars. But OSHA compliance, even though it's a regulation, doesn't. So when I was at OSHA, we did joint training sessions with the Joint Commission, because what they have in place is something called a referral system. So even though there's no requirement in the Joint Commission standards, which are in the infection control standards for hospitals, they only really address sharps disposal. But if they did see, if the surveyor knew enough to know that safety devices were required, they would then, after their survey, refer that case to OSHA for follow-up inspection. So, that may be also one of the things, even in absence of not having Joint Commission standards for sharp safety specifically, that the facility itself is aware that these referral systems are in place, and if they didn't have a sharp safety program, that the Joint Commission, even though they don't have a standard, could refer that case out for an inspection. But that's a lot that you would have to know in order to know that that process was even an option.
Interesting you say that, because in northern Florida, I'm in Florida. In northern Florida, there was a surgery center that had been inspected by OSHA, and they were very knowledgeable. And they actually forced the issue on, if you're not going to use a safety scalpel and you want to remain with a standard handle and a standard blade, you must use a single-handed device to remove that blade. And the AST, for example, says that specifically in their manual from last year, that you must use a single-handed removal device when using a traditional scalpel handle.
It's actually in the AORN guideline also.
Yeah.
And it's also in the OSHA bloodborne pathogen standard compliance directive, which talks about if you have to remove a needle or a blade, it has to be done with one hand.
One-handed. And you get, a lot of people get by that with the scooping technique, which personally I don't think really works all that well, but you know, that's the argument. All right, let me ask a different question. Do we really have to get legislation passed to force this issue? Whether it's smoke, it's blades, it's needles, suture needles, whatever?
So I'll just start with, there is already a regulation on the book for sharps. It's already there. There's not going to be anything additional that can be done that doesn't explicitly state that frontline employees have to evaluate safety devices and they have to be used. There's only 3 reasons why they shouldn't be used. One is if the safety device compromises the actual procedure, whether it compromises the patient or whether it compromises the worker. Otherwise, they have to be used. And what I have found during OSHA inspections for years is that there will be a surgeon who will say, we are not going to use this device, and then they'll have an exception form. They'll sign the exception form, they'll have it as part of their exposure control plan, and then they'll change the date every single year to be the same exception. There have been a number of citations issued for that very reason. So regulation for sharps is clearly not enough. There is enough out there. We just need to figure out how to make it more impactful. And to Monica's point, you know, that may be through increasing what licensure looks like for healthcare facilities. Like, for example, in Massachusetts, you have to report sharps injuries to the state. So the state is now keeping track. I think it's finding out innovative ways to make the regulations work better versus having more. Now for smoke, that's just for sharps though.
Well, adding on to that comment, if I may, most of the literature that I've looked at states that you're 4 times more likely to be hurt by a safety scalpel than you are by a standard handle. Any comments on that?
No, it just makes my heart hurt. I don't know what to say.
That's in the literature, and it's amazing. I think a lot of it has to do with just, you know, habits, whatever. But it is an issue. How do you get the message out? How do you get people to look at this as something that's important rather than, oh, well, I've got 15 other things that I have to do prior to going down that road? Yeah, that's the reaction I get usually when I ask that question.
I'll step up to this one, just my own opinion, but some of the things that I'm seeing out there. And the team that I work with, that we go out and do this consulting, is kind of a different approach to, and it's all safety and quality. We don't do any productivity or anything like that. But we go out with a surgeon, an anesthesiologist, a nurse, and a risk manager, and an infectious disease doc. So it's a whole different, and we just do surgical services. It's a whole different look at things, and it's all premised around a culture of safety. And I think that's the important piece. And if you look at the literature, many of these hospitals, they think they've got a culture of safety because they maybe have some safety devices or they're doing this in this unit or whatever. But it's that overall umbrella of a true culture of safety where you're building in reliability into your processes, you're putting systems in place that will withstand the human error. And that's a big piece of it. When a lot of these issues that we have are not because of the practitioner, but because somewhere along the way, the processes have failed them. And so I think those, from the top down, the administrators all the way down to the least person you consider, all are invested, each one personally, into an accountability for safety. And then we put the processes and provide them with the equipment and so on to reinforce that. But that doesn't happen overnight, as we talked about earlier. The literature tells you that it's a 3 to 5 year time frame to change any culture. So, you're looking at slow progress. Pat talked about building teams. Teams are really important. They help us to implement that we've got shared goals and that we're moving forward with the same mental model. And those various processes that the staff need to learn, those tricks, those teamwork processes, all build into this culture of safety. And you can have the regulatory and the lawmakers out there making laws, but if you don't have hospital administrators that believe and encourage this from the top down to the frontline practitioners and engage them in this, and that's the other piece. I have a really interesting, what did I do with that? It's called the, and I should have sent it to you. It's called the Iceberg of Ignorance. It's really interesting. It's from Sidney Yoshida, and he did a from the Quality Symposium. It's an iceberg, a picture of an iceberg, and above the water level, all right, is the problems known to top managers, and it's 4%. And then you come right below the water level, and the problems known to middle managers is about 9%. And then you come down another level, and it's the problem known to supervisors, and that's 74%. And then the problems known to the frontline workers is 100%. They're the ones that know what's going on. And if we don't engage them in the solutions, they're not going to buy in and they're not going to be part of that solution. So I think that it's really a very full culture across the system, the hospital, the system, whatever you're dealing with. And that's the outlook that has to be taken.
Well, let me ask a provocative question, if I may. And that is, do nurses really care about their own safety as a primary thought in the back of their heads when they go to work?
I think to a degree, and I'd like to go back to what Sharon was saying, getting the stakeholders, and also when you look at the different entities that are in the operating room, the surgeon, the anesthesiologist, and nursing staff. We need someone from every single group to be on these. We need a surgeon who's going to be your forerunner. We need to have an anesthesiologist who's going to support and be in a room where we have a difficult surgeon who doesn't want to do that. And also to have the staff working with the difficult surgeons, the difficult individuals who are saying, I don't want to change, I'm never going to change. And, it needs to be, again, a team effort, but it always needs to go back to, I always tell my staff when we're working on projects, I don't expect a nurse to be reprimanding a surgeon. I don't expect that. I expect that nurse to know who he or she needs to go to make the report. And then there should be a surgeon that not either confronts, or there should be accountability in their group, in the same way with anesthesia. If they're not using the proper things that they should be using and not wearing gloves and whatever. I remember a lot who didn't wear gloves back then. And, you need to have somebody who they're accountable to, and that person needs to go and talk to them. So it's not easy all the time. So that's what I'm up against.
That makes sense. So an ombudsman almost.
Yes.
All right. How do you create an activist? Final question for safety. How do you create within a facility an activist that actually wants to make a change and can be effective in forcing that change? Forcing may not be the right word. Facilitating, how's that?
Just going back, flashback to my director role, but I really think that you have to listen to your staff. They all have pet peeves. We all have them. Something, you know, those mosquitoes that bite you every day, just a little thing that bothers you. And that's, I think, how you get the activist. You engage that person to help make a change in whatever that is that's bothering them. And it's probably a safety issue because usually the nurses, the surge techs, they're geared in on what's keeping them safe and their patients safe. So I think that's one way that you can nurture and engage an activist.
Anyone else?
I would say there's a concept called positive deviance. I don't know if you're familiar with it, but it means taking an unlikely hero that has a message and is not afraid to put it out there no matter the consequences. And I think one of the innovative ways to do that is to do cross-training, meaning for new employee orientation, let's say, not having the nurses with only the nurses, but having the nurses with sterile processing techs or having the physicians with environmental services. Because you tend, when you do training only in professional groups, they tend to be very like-minded versus hearing a story that might be different, that might drive them to take up a new passion, to be a positive deviant. So I think cross-training is really useful for creating activists in places you may not realize they're there.
I think also the other piece that we've kind of not alluded to too much here, but at least what I've seen, and I've been doing the consulting for almost 12 years now, we have a huge lack of physician leadership when it comes to safety initiatives and quality initiatives. The university hospitals, they do a reasonable job because they all get their assignment and they have to participate in that. But when you get out into your community hospitals and your non-university settings, you know, it used to be that if you were going to be on the staff, you had to participate in a committee and so on and so forth. That's not the case with these physicians anymore. They want to come in, do their case and go. And unless you have that leadership, you're not going to get these nurse activists to tell the physician, engage the physician in what they want done. So that's a huge issue that I see out there today, where you really need to engage whatever initiative you've got going. You better have a physician champion on that initiative.
Right.
Monica, do you have any comments on this?
I agree with the everything that's said, and I think that I guess I'm just looking at my own organization and something that Sharon said, that I think the thing that the surgeons would listen most to is somebody on their own team and somebody who they work with every day, much more than if I said something to them. But having the person who is in the field or their beloved scrub tech or whatever appeal to them, I think would be a way to, you know, I think there's no way they would say no if that was the person who really appealed to them. And maybe we need to do that more of that at this hospital. We try to bring the tools to them and encourage them to use it. But the scrub tech is not going to be during the case saying, I think you should be using this product, or I think you should be doing this or that. But if we could get them with the surgeon champion outside of the OR to sit down and appeal their case, I think that would be helpful.
Pat, any comments?
I agree just what Monica said. You know, a colleague they will probably listen to a colleague. And by bringing up an incident that might have happened, that this is what happened because of this, and we don't want this to happen again, or, you know, we want to prevent some of this. So that's why we're bringing in this safety measure. Just having a sales rep talk to them, a lot of times that doesn't go over.
Yeah.
But by having a colleague share with them that they've been using it for, you know, a week or so, and to help them understand how they're trying to make things better.
I think COVID has helped their culture too. When they thought that there was a chance that it could be, that with the smoke evacuator, at least with that, they all were using it in 100% of the cases, and they all have their face shields on, and they all have their PPE, and really, because of that fear of something very real to them. But it shouldn't come to that. They should be more proactive and preventative rather than something like a pandemic to make them comply.
I think that's a really good point, Monica. I think also with the staff, that's another thing. And I think Pat might have brought this up with communicating to them, what are the sticks and the cuts and those kind of exposures. Frequently, they're not posted for the staff. And if the staff doesn't hear about them, they think everything's fine. It's just fine. We're not having an issue with any of this. So why are they pushing this, or why they haven't, So I think that's a very real issue. I'll tell you a real quick story about the best chief of surgery I ever worked with. And we were implementing, this was in Buffalo, New York. We were implementing the safe surgery checklist. This was early on. New York adapted it before it became the whole national standard and everything. And so we called ours the Kaleido Kiss. And so this, the docs weren't buying into it. They didn't want any part of it, blah, blah, blah. So he called in all the chiefs. This was a university setting. He called in all the chiefs and told them they were going to be part of this. So we'd have meetings and we'd talk about what's going to go on. We implemented this whole program. And then we were going to 5 hospitals. So in 1 week, every morning he made all of those chiefs show up at the hospital that we were rolling this out to. And we had bags of Hershey's Kisses, and he made those doctors go room to room talking to their colleagues about how important this was. And then the next day we go to the next hospital. Took a week. They were all moaning and groaning. They were so unhappy. But I'll tell you, it rolled out flawlessly, and that made the difference.
Interesting. Amber, any comments?
This is Brenda. I just wanted to piggyback on what Monica said, that having a staff person bring forward the idea is often a very, very good idea as a champion for something in the operating room. We have a nurse here in Atlanta she's a little tiny Asian nurse. She couldn't weigh more than 90 pounds. And when they were trying to implement, and this is a huge teaching hospital in Atlanta, when they were trying to implement smoke evacuation at that hospital, she didn't go into a lot of explanations or, challenges. She opened up the smoke evacuation equipment, put it on the sterile field, and she said, we're going to be using this from now on. And one of those surgeons was Sanjay Gupta, and he used it. So I think nurses and technicians don't realize how much power they actually have with the people that they work with every day. But it often takes only one person who can make huge changes in an operating room.
Amber, any comments?
I would echo that. I would say it's you just have to be fearless. It's something, and I hate to say it, but it's something that women struggle with on a regular basis. And I'm learning from this COVID pandemic, being busier than ever, that why be scared of anything, especially if it's going to save a life. We just need to speak up and be fearless.
Yep. But if I can, prior to closing, I have one quasi-related question. And Sharon and I have talked about this a number of times. And that is the definition of PPE. If you actually look at what the FDA calls it and what OSHA calls it, there's a one-liner toward the end that basically says that PPE is anything that prevents bloodborne pathogens from reaching skin and or clothes of the user, which would mean that in theory, PPE is not just something you wear, it's something that you use to prevent that from occurring. Anybody disagree with that definition?
I disagree with that.
Okay.
Because PPE is the very last resort. It's the worst on the hierarchy of controls. So it's everything you do. If it's not working, then you put PPE on. So if your work practice isn't working, neutral zone is the perfect example. Neutral zone I wouldn't even consider neutral zone and engineering control. I would consider it higher on the hierarchy, which is eliminating that hand-to-hand passing. If that doesn't work and you're implementing safety, and then technically you're using personal protective equipment. So I would even argue that PPE that's used in a surgical environment isn't really personal protective equipment because people are wearing it to protect the patient from them. So it's really about how you're thinking about PPE is not to protect the patient from you, it's to protect you from the patient. So if you've done everything on the hierarchy and there's still risk, then put on something. Then wear a respirator, then wear a gown. But really that's, the lowest level of control. It requires that it's available. It requires that the right thing's available. It requires that you put it on right. It requires that you take it off right. It requires that you dispose of it right. I mean, there's so many elements within the definition. So I would say the definition matters less than what the intent is.
Okay.
This is
Any
right.
other-
There are some pieces of personal protective equipment that do protect the user from the patient, like an N95 respirator or
Yep.
a true respirator. Those do protect the nurse or the doctor from whatever they're breathing or coming in contact with in the operating room.
And I think that's been the long time disagreement between occupational health and infection prevention. Because PPE for an occupational health practitioner like myself is to protect the worker from the hazard, and in this case, the hazard is the patient. But in infection prevention, as you mentioned earlier, Al, it's the reverse. So infection prevention is to prevent healthcare-associated infections, which is to protect the patient from the worker. So again, it just comes down to the intent. Who is needing to be protected? Is it the patient or the worker? And I think from this evening, we've all decided that it absolutely has to be both.
Right.
Exactly.
And
Yeah,
the
I agree with that.
PPE in the OR is both. Alan, I would draw your attention to the guidelines for AORN in the glossary on the SHARPS safety guideline. There is a definition of personal protective equipment, and we'll have this discussion further. It's quite interesting.
I'm looking forward to it. We'll do it over a glass of wine.
Absolutely.
In any case, I'd like to thank you all for participating. It's been really interesting. I hope you got something out of it and at least enjoyed the conversation. And having said that,
Thanks for the invite.
Thank
I
you.
will make sure that you get a copy of this discussion. It will be advertised in September on OR Safe and be then put on the website in October. So
Okay.
if anybody has any issues, please let me know. Otherwise, thank you very much. It was very informative and hopefully a useful discussion.
Thank you much.
Good night, everybody.
All right, good night. Have a good one.